Good morning, everybody. We have a session called Vapors, Video Assisted Problem Oriented Retinal Surgery. I'll request Dr. Puneet Gupta and Dr. Murli to come on stage. We have three Vice Counsel, Dr. Mahesh, Dr. Pramod, and Dr. Reddy. Please also come on stage. Muna, where's Muna? Muna,
Yes, some other session. Not aware, you may not be coming. I think Rajiv is not coming. Because Rajiv, morning he met me saying that there's a concurrent session going on and then he's not coming. So, what's coming? You want to take a check?
We all are wise.
So our session is basically video oriented. We'll have a short video of 2.5 minutes where the surgeon will present some interesting facts where they've got stuck in some surgery or some innovations. And then we have experts to give us our expert opinion over them. So we have about 10 presenters. I think we start with Dr. Mudit Tyagi as first. Dr. Mudit Tyagi.
This side? All right, so good morning, and first of all, let me thank Dr. Amit Khosla and the scientific committee for having me here for this very interesting session on vapors. And what we will be showing is one more interesting application of some of the work which we have been doing on fibrin glue since the last some years. So this is where fibrin glue can come to our rescue in some of cases where we may have iatrogenic inadvertent breaks or where we can have a single break with a detachment over here. So let me show you a video. This was a lady with SLE and had a tractional detachment and a vitreous hemorrhage. And this case was being done by one of my fellows, and initially everything was going on well. You can see over here the fact that most of the hemorrhage has been cleared. But underneath that hemorrhage, there was one small area of traction, and this is the area of traction, and this, look at what's happening over here. So while removing that traction and pulling over here, there was an inadvertent pull that created a break over here. We did an OCT, intraoperative OCT, and what we found was there was an inferior detachment. Now in earlier cases, what we would have done is we would have either left gas or air because this was a detachment which was extending inferiorly also. But here what we did was we initially did a fluid air exchange, settled the retina, subsequently did a laser. Around that I will skip that part in the interest of time. Did a complete laser, did a PRP because there was a lot of peripheral ischemia. So what we did in this case was we did an extensive peripheral laser in the areas of ischemia, and subsequently after doing a laser around the break, what we did over here was that under a complete fluid air exchange, what we did was we put a drop of fibrin glue, a thick component, followed by a thin component that creates a coagulum which you can use to tamponade. A coagulum gets formed which we just lifted and deposited over the break. So you can see a attached retina under air with a fibrin glue coagulum which is adequately covering the break over here. And that's the end of the story. That's how fibrin glue can come to our rescue. In fact, in this case, we decided to leave the eye purely under fluid also because now in most of our cases, we have started removing air also so that we get a clear media. So this is how the patient was at the end of the surgery. And this is what we are talking of. So this is the patient on the first post-operative day, where you can see a completely attached retina with these laser marks and this coagulum covering the inferior break. This is how the patient is at 1 week, where the entire coagulum started getting resolved with an attached retina, visual acuity of 20/25, which is being maintained. So that's how fibrin glue comes to our rescue. I can just take a very small moment to just show the schematic. The steps are essentially absolutely similar to what we do in a conventional vitreoretinal surgery with vitrectomy. You do a fluid air exchange, settle the retina, do a laser around the break, and subsequently after doing a laser, the only different step is instead of putting oil or gas, you just put a drop of fibrin glue which acts as a coagulum covering the break, and that takes care of the entire thing. So in a nutshell, like I have said so many times, and you don't need to give a post-operative positioning to any of our patients because you are leaving your eyes under air or fluid, you get a very early visual recovery. So this helps us in an early visual recovery with no post-operative positioning and helps us in avoiding all the problems which gas or oil tamponade bring to our lives as vitreoretinal surgeons. Thank you so much once again.
Very interesting videos. How much time does it take for the fibrin glue to act? Minutes?
So it takes just around a minute for the coagulum to get formed. So you do a fluid air exchange in a air-filled globe, just put 1 drop of fibrin, wait for just a minute and a coagulum gets formed. 1 to maximum 2 minutes. And that's all.
So if you had any failure, like to share your experience of failures with fibrin glue, what are the tips what caused failure in your patients?
So one of the most common causes of failure can be a very large break. So if a break is very large, usually we reserve it for eyes with simple detachments, 1 or 2 breaks close to each other, smaller breaks. If it's a very large break, more than 2 disc diameters or very large break, what happens is that the coagulum tends to go subretinal. So that is one of the cause of failure. Multiple breaks in multiple quadrants is another cause of failure. And once we had a failure which is slightly embarrassing to say, but I ended up when I went for a repeat surgery, I realized that there was a missed break which I had not been able to visualize. I usually have an OCD where I try to indent again and again to check if I've missed any break, but there was one separate break which I had somehow missed that led to the failure. But conventionally, otherwise, large breaks in multiple quadrants are contraindications to this technique, relative contraindications.
When you use it for a cornea or sclera, generally effects start going on third or fourth day.
Yeah.
Okay, maybe external effect also there. So actually now you have a serial photographs, how long that glue holds on, because we need somewhere window of 9 to 11 days, 2
Yes.
weeks suppose, that's why we say 2-week prone position. So you have photograph evidence now. So your glue, that how long it stays there at that rate?
So before that, sir, so there are reports and there is literature where they have shown that the effect of a laser laser pexy starts coming within 24 hours.
Yeah, that is
And
there,
by
yeah.
48 hours, you get a nearly complete effect of laser. So technically, we need a tamponade which can only cover for 2 days to 3 days at the maximum. The pitfall is that most of these studies were done where they detach the retina immediately and they reattach it back. So obviously the adhesive strength and the pexy in a retina which has been detached and then reattached immediately, which will be much more quicker than what will happen in a retina which has been detached for a longer period. So therefore we thought, because we do not have any study to validate it, but we thought that if it is taking 2 days in our retina in those cases, probably by 4 days to 5 days the effect of laser should be there completely. This glue, we have done serial photographs, stays for at least 5 to 6 days, sometimes even till 8 to 9 days. But in most cases, by 2 weeks, the coagulum completely goes away. By 7 days, you start seeing a resorption of the coagulum. So enough for us to have an adequate tamponade effect.
Yeah, so you want to have a coagulum little bit much larger than a break size, so that even if retracts, you still
Yeah.
it still lasts for
As-
about 10 to 2 weeks.
So that inadvertently happens. It's a liquid. You drop over here, it will spread slightly. In fact, that's why you saw that it tends to trickle down. You have to lift it and deposit it back to some extent. But it does end up adequately covering the break.
Does it work when there is some little amount of subretinal fluid?
So ideally, you have to ensure that it is absolutely dry, because if there is subretinal fluid, then also it will tend to go subretinal. It will migrate also more subretinally. So you have to ensure that it is absolutely completely dry. Do a fluid air exchange, ensure it's absolutely dry, and then put a drop of fibrin.
No, basically what you're looking at cyanoacrylate glue.
Yeah.
You need absolutely dry surface. As against it here, it will work both even if a liquid fluid is there. But the issue is with the fluid you put it, retina is always elevated, it just sits under the
sits in
retina
over
rather
there.
than sitting over it.
Yeah.
That's the only issue.
So what about in a diabetic TRD? You create a small break in a lasered area.
So we have done that. We have started using it in some of our diabetic TRDs. We have just published one report where we have used fibrin glue in complex detachments. We have started using it for disc bleeders where it works for hemostasis. We just did a randomized control trial where we compared the effect of fibrin glue on disc versus in eyes where we did not use, to compare the effect of preventing recurrent hemorrhages and bleeding. So we have started now exploring it.
Not be a barrier to the coagulum.
No, it will not, sir. You do a dry up over there, you remove as much of blood as you possibly can, put a drop over those bleeding vessels, it helps in coagulating those also.
You tried various glues, or the Indian ones also work, or which
So
one do you use?
till now we have only tried Baxter. I have not tried any other company, but one of my colleagues in Coimbatore, Dr. Ashray Nayak, has started using Relisil. He told me that it's working well, but I haven't had the time to try it. I haven't had a chance to try Relisil. But now probably there's a shortage of Baxter that we are facing in our institute. So probably now the only resort I have is to go ahead and try Relisil. I'll update you on that. But I haven't tried till now any of the other companies.
The cornea people are I think using, but
Yeah, we haven't. There's one more company called Fibrosil. No offense to the company that makes it, but it causes an intense inflammation. We have used it, and the next day the eye was full of vitritis. I nearly had a heart attack, but luckily the patient recovered in the next 3 to 4 days.
no, that's the only concern we have. That's why I'm very hesitant to use. That's the only thing what you said.
No,
is-
but for Baxter, we have now used it in more than 150 cases, sir. Across, if you look at the entire spectrum of macular holes, TRDs, and detachments, Me alone, more than 150 cases. My colleagues also have used it. So cumulatively, we may have probably done it in around 180 to 200 eyes in LVPI. And the only eyes where we saw a reaction or vitritis was the other company. With Baxter, we haven't. Only one case where one of my colleagues who was doing it the first time probably ended up injecting too much of it. It was like unphysiological concentration of too much of fibrin inside the eye. But otherwise, when you use it in a controlled way, not even a single case of increased inflammation.
How do you do it? Macular hole, it works?
Sir, macular, so what we have been saying is that fibrin glue is a substitute for tamponade. It's not a substitute for a scaffold. So if you're doing an eye lamp peeling, there are people who have tried putting a drop of viscomat over the flap to stabilize the flap. People have used PFCL drops also. I was having a discussion with some of my friends in Taiwan. They are now doing some technique where they put just a drop of viscoat over the flap. So we have tried doing it where we have reposited a flap or did an inverted flap, and on top of that we have put a fibrin coagulum. So that helps in obviating the use of a gas in some of our patients who are not able to maintain positioning. But it cannot be probably a substitute for the flaps or for ILM. It's basically a substitute for tamponade. That's how it works in detachments also. That's how probably it even works in macular holes.
So you said initially that you used air in some of the patients initially.
Yeah.
So what was the purpose of using air? if
No,
the temp-
you do a fluid air exchange and
I mean, you leave air.
I was just leaving air behind instead of removing it. But then I thought maybe let me just try whether it's working, because there will be this question where people say that this detachment actually got settled just because of the fact that you have left air inside the eye. And we were seeing whether it works or not. So that's the reason we initially started removing. Because it's working now, I have in most of my cases started removing air also. You can leave it behind, it will actually save you another 5 minutes. You don't have to wait, just leave it under air. You don't have to bother about it.
Initially, so I was not sure whether how it's going to work.
Yeah.
So initially, you want to have one, then transition, and then move to
Yes.
other one. I think that's the way. Now I think he's more comfortable.
Yeah. So now I am convinced, so I have now started removing it. In our initial cases, we left some of them under air also.
How much do you charge more for the patient?
So we don't charge more, it costs around 8,000 rupees. Which
Correct. But like you don't charge for the patient?
we do charge, we put it, but then we are not charging the patient for oil or any other thing. So in
Correct,
terms
but
of
this
the,
particular patient wouldn't have needed oil. If I was managing this patient, the one you showed.
sir, luckily for me, this patient was a patient which was anyways getting a surgery done free of cost. That's probably the advantage.
Even otherwise, like this is a localized detachment, and
Yeah.
the traction has been relieved, and if in case you just leave it air for 2 days, it should have become okay. I wouldn't put gas in this patient.
Okay.
So otherwise, like this additional cost of 8,000 is there. Of course, like not all the patients where you would need oil, you can manage with fibrin glue. That's one thing I have. Other than that, I have used it in optic disc pits with, I have used a scleral, what do you call the
Scleral
graft,
patch, yeah.
Scleral graft, and then there was one particular child where you could see it getting pushed out.
Yeah.
Sufficiently large graft, I put it inside, pushed out, then I put 2 grafts, despite which it pushed out, then ultimately put 2 grafts and put a drop of fibrin glue. So I have used fibrin glue, but as I mentioned once, like I did have an inflammatory reaction in one particular patient. But then the cost is one, another one is like you have to be prepared. So in our hospital, whenever the cornea people use it and then they have it, the residue left over is when I use it. I don't.
That's what happens to us also. That's one advantage I think we have because of an institute, that there will be multiple ORs running and you can just borrow it from the cornea OR.
Thank you, Dr. Mudit.
My understanding, the release seal doesn't work as good as the.
So that is what even my understanding is till now. It's just that now.
Correct. The thing it doesn't work as well as the back seal. So we have tried release seal, but it doesn't work as good as the back seal.
Okay. Because my cornea colleagues are very unhappy with Relisil, to be honest. But one of my friends who started using it told me that he's getting good results with it. So I need to try it. But I haven't tried it till now.
I think we are running
Yeah, sure.
with
Thank
time.
you
We
so
can
much.
have the next person.
Next, we have Dr. Gagan Bhatia.
So, I think the topic for today, good afternoon everybody. So the topic for today was basically amniotic membrane grafts, and why I call this beyond pits and macular holes, because we've already worked on beyond pits and macular holes. So this is a series of just 3 cases, complicated cases where thought of putting this. So this was the first case, was recurrent RD, which was operated elsewhere. So we got these multiple holes, sieve-like holes next to the macula and a huge macular hole. So we did a partial fluid air exchange and then inserted a amniotic membrane graft. So I think this part of the surgery which is basically using AMG grafts for macular holes has already been published. I think we've worked on this extensively, but this time I tried and started covering the rest of the other holes also, because doing extensive laser in that area again, or doing touching that area would probably just make a huge posterior GRT kind of a thing over there. So we went ahead and covered these with 3 pieces of macular holes, so 3 pieces of grafts, and so we use a dermal trephine basically to size these grafts into perfectly round AMG grafts, and then the temporal edge was basically laser and oil was put in situ. So this was a post-operative photograph, and then if you see those laser marks on autofluorescence, and the graph is amalgamated extremely well. This was the second case, which was a TRD patient, extensive TRD done elsewhere. Again, this was so there was a huge retinotomy at the disc, and the tissue left at the disc was extremely very small, and at that last moment, I was called into the OT, and I had this idea of why not use a graft over there. At this, obviously the graft size was not measured, so just took a large graft, and the idea was to tuck in a little part, because the first time I was putting an AMG graft to cover next to the disc. So this idea also came from as I had seen a similar kind of a surgery elsewhere, and it covered it was beautifully covered again, and this is the post-operative photograph. This third case was again a large recurrent detachment, which was kind of offered with a very huge hole, and this was actually the first time that I had put a graft, used a graft to cover a large retinotomy. The idea of using the graft here was again because it was the temporal edge could not have been lasered, because the temporal edge was bang at the fovea or just at the margin of the fovea. So this is a technique that we use. We already published it with the triple S technique. So we stain the graft with brilliant blue dye. At this place we took obviously a corneal trephine, not a dermal trephine, because it was a large graft, and then finally this was put through. Usually it's better to do with a 23 gauge, but in this case, because the graft was large, we took a 20 gauge sclerotomy, and with the bimanual technique basically place the graft as an underlay. So ultimately, I think the patient improved vision to finger counting 4 meter, and the graft showed perfect adhesion with the retina. Thank you.
Any comments?
Macular hole mechanism, we know different way the way it heals, but other breaks need a retinopexy. So, I mean,
Sir,
that's what,
as of now, yes, I do agree with macular hole. How it heals is definitely known, and kind of. I was trying to get an OCT through the second case, which was basically the retinotomy very close to the disc. So that's a very fresh case that I just done a few weeks back. So the OCT currently is showing the ingression of the pit, the AMG into the the retinotomy. So probably the mechanism is going to be the same. The third case which I showed is almost now I have almost an year follow up with that patient. So that patient again, it kind of amalgamated the same way. So I was actually visiting Dr. Carlos, and he had shown me this, his cases where he started putting he's using a dehydrated graft basically, and this is a cryopreserved graft. So in the dehydrated graft, he actually shows that it kind of goes into the trough and then it comes up. So it fills that gap up, and then slowly the part which is epi-retinal, that kind of absorbs away. So if you see the first case, that's exactly what's happening on the OCT. So probably it's just going the same way. And even on those micro holes, it's kind of gone dipped in, and then it's kind of engulfed or kind of sealed that area off, and then it kind of the upper part kind of absorbs. So still needs to see how it goes. But yeah, with optic disc pit, I think macular holes we've already published, and we're on the way to publish for optic disc pits. Optic disc pits post now 1 year of follow-up, the graft is staying there. It's not going away. So still need to see whether for extra foveal
will it disintegrate over a period of time or not, whether it's going to be.
Yeah, it's gonna work. Yeah.
I think from what I know, it stays for years. I think
Years,
I
yeah.
remember, forget the doctor from Hyderabad, not Visakhapatnam, Velli Prasad, he presented it many years back in
Yeah,
Rednet.
and we had
actually.
this Nayak, Samira.
Samira
Almost
presented
2 years.
2016
Rednet.
she presented.
Yeah, Rednet it was
Yeah,
there 2
she
years back.
presented, no, 2016 only she presented. Many years back she presented. And if I remember it, the follow-up, the amniotic stayed on for many months or years it stayed on. So, it works. Only thing is after it absorbs, what happens, we don't know, probably by the time the RP
It kind of regenerates and all.
functions so well that it doesn't regenerate.
Yeah.
It doesn't allow the detachment to happen, and it's a posterior break, so probably it doesn't matter too much, the traction is relieved. And the last case, yes, there was a little bit of retina temporarily, we can still do a little laser photocoagulation to cover it. Two things, one is when you cover the macula completely, whether it does become translucent and the patient is able to see through it, but sometimes whether it interferes with the visualization of the light reaching the macula is something which we don't know. When you put it there, it looks opaque, and after that it's integrated so well you can't really make out what is happening. I would also agree that the OCT which you showed last, it seems to be integrating so well into the retina. And so I am not too sure what is the need to put it underneath the retina. I can just put it on the surface, then maybe it will still work.
Yeah, so we've tried overlay and underlay both, and they both seem to be working the same.
No, underlay kind of there is something which is interfering with the retina and the RPE, so whether it will interfere with the adhesion is what I was thinking.
So that is what, there is a case which was probably I think it was the second case of macular hole that we had done, which was a recurrent detachment. And it was a very high myopic lady, and there was no other way to do it. So we put a macular hole, we put an AMG graft, which was an underlay. And the most surprising part about this, because that time we were just understanding which is the chorion side and the amnion side and all that. And so she had a recurrence post the surgery, AMG surgery. Everything went off well. She had a recurrent RD post 1 year. And I was extremely surprised to know when the retina detached, the macular hole did not open, and there was a continuous band over there. So it absolutely integrated with the retina. So I don't have the image right now to show because I don't have my laptop, but I was also very surprised because they talk about it adhering to the RP ultimately in an underlay technique. But over here in an underlay technique, it became a single band. So,
Dr. Samira also I think put it under the retina earlier.
Yeah.
Now I think the concept, some of them probably put it on the surface
overlay,
and overlay and just leave it like that.
Yeah.
Just one last comment is how did they manage to create so many breaks in the first case?
Yes, towards the RP. Yeah.
Actually, is there any formal study comparing the overlay versus the underlay?
No, sir, we're working on that. So I had presented the optic disc data and macular hole data in VRSI last year. So I had the similar comments, and there are now people I've collaborated with and working on an overlay underlay comparison. Because we were primarily doing only underlay. Now only we started doing overlays. So
the next question actually comes: how much do you extend beyond the break?
So as far as disc pits are concerned, we are taking the exact linear diameter, the largest linear diameter. And most of the cases, I have a series of 6 cases now, and most of them have been around 700, 800 micron disc pit size. So we're taking a 1 mm kind of a thing because you need to tuck it also a bit. And as far as macular holes are concerned, we basically made a, kind of evaluated over cases and made an equation where we have the basal linear diameter and the top diameter, and we kind of average it out. So it covers roughly around 0.5 mm around in an underlay technique. Overlay you can put huge. So that is what with Dr. Carlos, I think he showed huge sheets because that dehydrated is very easy to put in because it stays like a sheet, like a chocolate brick. So you just put it on top. So he's covered the disc as well as the macula and everything.
In one.
So, yeah, in one go. So
The only thing is how do they enter into the?
You have to remove this clear thing, the trocar cannula,
Yeah.
and then
put it
roll
in.
it and then put it inside and then open it up.
Thank you, Dr. Gagan.
Thank you.
Now we have Dr. Navneet Mehrotra who will be presenting an interesting case.
Good afternoon, everyone. Thanks, Dr. Amit Khoshla, sir, and for giving me an opportunity to present in this forum. This is a case of a 21-year-old female who came with vision of 6/60 in the right eye. This was the posterior pole. There was an epiretinal membrane. Okay. So this is a case of a 21-year-old female who came with vision of 6/60 in the right eye, and that was the picture of there was an epiretinal membrane in the right eye, and this was the left eye. This was a case of an familial exudative vitreoretinopathy. This in the left eye was 6-6. OCT in the right eye showed traction at the macula, and this was the fluorescein angiography. There was an inflammatory kind of leakage in, and also there was a lot of neovascularization in the periphery, and we can see in the lot of capillary non-perfusion area, which was as what we see in cases of FAVR. This was the surgery. We removed the membrane, and after removing the membrane, this was we used contact lens, and we did it with HRX, and this was then we removed the membrane from the disc. That was very tightly adherent at the disc. So after removing the membrane, this was like pulling out the membrane from the disc, and it was very much adherent right at the disc, at the macula, and what we expect in cases of FAVRs. Most of the cases of FAVR, because it's a kind of process which is gradually going on and cause an inflammatory kind of reaction, and exudation and an epiretinal membrane, a thick epiretinal membrane formation in the macula. So while removing from the after removing from the macula, we can see that it was also very much adherent to the vascular arcade. And while removing from the fovea, like there was a small bleeding, but we could manage it, and there was we could separate it, and did after staining with ILM, and did ILM peeling also. It was after ILM peeling, we suspected there was some hole in the mid periphery, and did laser to the periphery and also cryo to the peripheral area. As you can see in the periphery, there was a cryo also been done. So did fluid air exchange, and injected C3F8 at the end of surgery. Patient was doing well. Patient with post-op day, this was the picture, and after 2 months, she gained vision of 636, and I was stable. Patient lost to follow-up, and then she came after 3 years, and this was the picture after 3 years, and she developed exudation in the periphery. We again did angiography, and it is still looking like an inflammatory kind of appearance in the right eye, and left eye, the same lesion. We agree that the laser was inadequate in the left eye, but the lesion didn't progress in the left eye. It was almost the same even after 3 years of follow-up. I also wanted to show very similar cases, like this is a case of an 8-year-old boy. He didn't undergo any surgery, but in the right eye, there was an inflammation kind of thing, what we can see in the fluorescein angiography. But in the left eye, he came with high IOPs, and in the left eye, there was area of capillary non-perfusion, and we did laser in the periphery in the left eye, and right eye we kept under follow-up, as we couldn't see any area of this. And this is another case of 23-year-old female, and this is post-surgery in the right eye. And post-surgery, like what we can see, this is there was an inflammatory kind of appearance in the fluorescein angiography. And the left eye, we did laser photocoagulation. She is stable. So with looking at these cases of FEVR, what we feel like many times we see it's an asymmetric presentation of FEVR. Also, something like an association of inflammation in FEVR, role of wide field angiography, and one eye at times progresses fast, one eye may remain stable for years. And is there any role of local steroids, or role of local immunosuppressants, like what we give, methotrexate, what we can give, or systemic therapy like systemic methotrexate to stabilize one of those eyes, because these are the progressive conditions. So just a few thoughts like about this. Thank you.
I agree that like it's like the fern pattern kind of a leakage is what you're seeing.
Yes, sir.
But that if it is inflammation, there is nothing. The vitreous is not involved in that sense of the word, except for the fact that like if there is a leakage, it's there. So can't say if it's really an inflammation or if it is the capillary leakage because of the overall vasculature being abnormal. So no, but like it's not. It's like a fern kind of a leakage from the capillaries. So the only way we can answer is probably, as you said, you can probably put the patient on steroids or immunosuppression and then repeat the FFA. So that would be the best idea actually. So if you can put the patient on treatment for about a couple of weeks and then repeat the FFA and see if this leakage goes away, then we can probably conclusively prove that there is an inflammatory component involved. Then we maybe there is a justification to use intravitreal steroid or oral steroid or immunosuppression is what I would think. And very well managed, but otherwise, like, these are the patients which can bite back. These are the cases which can bite back actually. FUVR is sometimes very, very difficult to manage.
Yes,
They do develop extremely difficult detachments in the periphery, particularly if they are young children. So the ones who present very, very young, almost like ROP they present, or about 5 years, 7 years when they present, they are the ones which you would have to struggle hard to keep them seeing. So despite whatever you do, they continue to worsen, and these are the patients I would usually not go inside at the initial step. Like, I'll probably think of doing buckle, try to do everything else rather than going inside. So once you go inside, then the picture becomes difficult to manage.
So looking at this, we have started giving intravitreal methotrexate. We don't have any current like data and everything, but hopefully there may be some stabilization of these eyes, because especially we have seen in eyes which we operate, I think they don't do very well.
That's what
Yes,
like, it will be a great idea
Yes,
if in case you can do an FFA. You
Yes.
just repeat the FFA about a month after you start the treatment and compare the pre and post treatment FFA and see if in case like your immunosuppression or steroids is having a positive effect. That will be a great learning tool for all of us as well.
Thank you, sir.
Yeah, I agree what Mahesh said. Basically, they are difficult to handle, but also important is you have to keep on trying, because it's eventually sometimes it's happened the worst eye probably turn out to be seeing eye, and the one you think is good one, long-term follow-up you see they lose the better eye, and that's why early treatment, the other eye particularly knowing and you're doing it FEV are dealing with probably rather than just watching no exudation, probably I would just laser it off. I mean, these eyes you need to be very, very aggressive as far as laser and things are concerned. Anti-VEGF, I'm not sure whether they really work, because mechanism is different here. Okay, people have tried anti-VEGF and they have contrasting result as well. But most of the time, overall, in general, we agree anti-VEGF probably will not have effect, but you can land up in a crunch subsequently. And when you're operating, probably yes, vitrectomy, even if you do just to relieve the traction and probably support with buccal, never ever do relaxing retinotomy. Probably most of you do RR and then you lose the eye. Actually, you will not do that. Retina just doesn't settle. Just whole thing rolled up and then you lose those things.
I have two questions. Like in the first case, like the patient has followed up after 3 years. So at this stage, like now she has developed some exudation in the periphery. So at this stage, would you prefer to do buccal, prophylactic buccal, like in these cases?
No, prophylactic buccal, if you have you feel some
Kind of
traction is there. Because it's not like that if you do buccal and then traction will not develop later on. Not like that. But if you have a traction, then to counteract that traction, rather than doing vitrectomy, because vitrectomy, again, you cannot induce PVD in these eyes. That means you will not be able to relieve traction completely. So in that situation, I would try buccal. Rather, of course, you add laser or cryo, whatever depending on area you are treating, and then add a buccal rather than going for a vitrectomy.
Role of implant, Ozodex implant, dexamethasone implant, role of.
No, that's exactly what you're asking about, whether role of steroid, whether if it is inflammatory pathology, probably not, which most of us know now. So whether dexamethasone or whether you are anti-VEGF, I mean, really, I don't think. So anti-VEGF, they talk about probably it will help, may reduce the exudation, but as such, basic pathology will remain same. Again, it just bounces back. And land up in a crunch, that's another problem.
A little concerned about the dexamethasone implant in this period, because the vitreous is abnormal here, and particularly if there is a little bit of traction, you can see the dragging of the retina towards the temple periphery. I would be a little bit concerned about putting a dexamethasone implant, which has a rough surface, so it can alter the way the vitreous behaves. So, as I mentioned, if you can really do an FFA about 2 to 3 weeks after you start the treatment, then that will really be a good learning tool for all of us. So I'm a little concerned about the dexamethasone implant in these situations.
Thank you.
Thank you, Navneet. We have Dr. Sanjeev Hansraj next to present an interesting case.
Hello everyone. We as VR surgeons are also called upon to manage complications of the anterior segment by anterior segment surgeons or surgeries which have not been done properly or some problems. So here is one of such case. It's basically it's showing a new design, recently available design of a scleral fixated IOL. So this was a patient who had been implanted a wrong powered IOL, and that also a badly done surgery and with the SICS, and it was. Do I have to play this? So the patient had a vision of 6 by 18, but with a -7 diopters of refractive error. This is the design of the lens which I plan to implant, because it appeared to be mostly we are doing scleral fixated IOLs by the Yamane technique or modification of Yamane technique, and it has its own learning curve, and it has a lot of things, manipulations and etc., which can turn out to be a little tedious. So this appeared to be attractive in the design and in its method of implantation. So I decided to go for this kind of a lens. You can see that the iris is distorted, the pupil is pulled up, and the SICS incision has been done, and the IOL had been lying in the anterior chamber, so it distorted the pupil and caused the pulling up of the pupil towards the incision, and there was a scar at the limbus, a big one. So the IOL had to be explanted first, which was done through the SICS incision. Then this IOL is being implanted, injected into the eye, and it has these two, at the ends it has got these two haptics which need to be T-shaped protrusions at the end of the haptics, which are closed loop haptics, and these are supposed to be pulled out of the incision, and they will stay there because they are larger than the size of the incision. So being used to now almost by default doing 25 gauge surgeries, here also I went in with the 25 gauge trocar cannula system. I did the two cannulas trocars were inserted in in the position where the haptics, in the horizontal meridian where the haptics were to be taken out, exteriorized, and it is being done under a mini scleral flap so that it will get covered later with the sclera. So while taking out, so I used a 25 gauge maxi grip forceps by Alcon, which is the one we use for doing the Yamane technique three-piece foldable IOL with Prolene haptics or PMMA haptics. So one is used to that, so that is what I used. So here I encountered the difficulty in exteriorizing, because this haptic is a little thicker, and when being held by the forceps, it broke. So then I realized that the mistake was in the size of the sclerotomy. So I made a 23 gauge, as corrected, made a 23 gauge sclerotomy, and I pulled it out. The haptic was partially fractured, so instead of a T, it was like a L. So I decided to anchor it at the sclerotomy with a 10-0 nylon suture so that it would stay there while I exteriorize the other side. So this is being shown here, being sutured to the sclerotomy, anchored there. So after doing this, then I went ahead to the other side and exteriorized the, so here this is being, it's just a L being sutured. So this is the sclerotomy is enlarged, and then this is successfully taken out, and you can see that small little T which is outside, it's larger than the incision, so it stays there. But in the process, what happened that I lost this side haptic, went inside completely, and the IOL was dangling inside. So now I had to rescue it. So I decided to use the sutures to fixate it. And seeing that large closed loop hanging inside, it was very inviting to put a suture through it. So I used the Prolene suture. Unfortunately, I did not have a straight, this Prolene suture comes in the, with one side is having a straight needle and the other side has a curved needle. So I had the curved needle with me. So I used the free end of that suture and passed it through the closed loop and exteriorized it by holding it with the forceps. Then the tricky part was to pass the suture, the other end, which is the curved end, which is still outside on the right hand side. So this I had to manipulate with the forceps. So by holding, I did it by holding it at the tip and successfully brought it out. And then I sutured this to the sclerotomy on the left side. So ultimately the result was all right. The IUL was properly anchored and it is stable. The patient has already now had a 2-month follow-up and she has recovered satisfactory vision. So this is just a learning experience in the use of this IOL. It is a good design in the sense that it is easy to use, but one must have a 23 gauge, one must use 23 gauge instruments in order to do it successfully.
I think
So that is the.
Yeah, one lesson we learn is that whenever you're doing a scleral fixate, you must have a standby lens, whether
Yes.
it's CMT or it's a multi-piece lens which you're putting. You sometimes have a breakage of the haptic.
Correct.
So standby is important. So how many millimeters do you do, and do you do a wide to wide before you take up these patients?
Yes, yes, I do a wide to wide. I use about 1.5 to 2 millimeters away from the limbus. I make the incisions, and the wide to wide in this case, this lens is 13.75 millimeters in the overall diameter.
So one suggestion I have is what I use, that you use the 23 gauge, and you take the forceps through that, and you take it out with, and you pull the trocar in one. So don't take out the trocar. Go through the trocar and catch at the junction. What it breaks because you're catching the T.
Yeah, I'm catching it
Catching
at
one
the
of the loops
junction.
of the T.
At the junction where the T is the T where it is meeting with the limb. So that is the place where I hold
that
it.
is-
Yeah,
So
that's where
go
I.
through the trocar. I've had one patient where it slipped later.
Okay.
So after a few months, 6-9 vision, it slipped. So I think anchoring would be better because these hydrophobics are really foldable. I don't know what is your experience. Any of people have a pacification of these lenses ever? Nobody's used the CMT.
How is
I
your
think the
experience
lens is a little relatively new, so I don't think there's a very long follow-up. I have done a few cases after this, so they are all doing well. There is no deposit. There's another company from Ahmedabad which also makes the lens. On that lens, I had deposits, but then the deposits, it can be variable. It depends on whether there was inflammation in the eye, what kind of initial pathology there was. So, in those circumstances, there can be, it's difficult to comment on the quality based on that. So, but
Pramod, we make
most.
it incision at 3 and 9. Do you think that is safe? Exactly 3 and 9 we tend to make the incision.
No, that's exactly concern is because you go on either side because the long posterior ciliary vessels, that's little bit risk you take because even I had a problem not with lens. Once happened, one of my fellow did one sclerotomy there and we landed up in massive supracaudal hemorrhage and vitreous cavity hemorrhage. We lost the eye eventually, that one. So I would prefer just go off 3 or 9 o'clock.
Yeah.
Because when suture SFIL you do properly, if you're taking 2 suture, you always have one either side, not really exactly 3 or. It just happened quiet. You are lucky enough, you just miss that vessel and nothing will happen, but you never know. That's why I would prefer, just relevant observation.
How do you mark the 3 and 9? Which patients are using
You use a marker, you use a corneal marker which is a hemispherical marker, so that is the way of, you can divide it into 2. With this lens, one can do it a little diagonally. It is easier in this case because you don't have to do much manipulation after you've taken out the exteriorized. But whereas in Yamane type technique, when you're doing scleral fixation, then you have to, tuck in the haptics also. So then it becomes a little tedious, especially on the.
The only problem is that if
Right
you pull
side.
it, you pulled one loop out, you pull the other loop. If you give excessive traction, the first loop tends to come out. So either we suture it. I feel
Yeah, so what I do is that I don't have a video of that, but what I do is that I use the small silicone bungs which come with the iris retractors. So I put that on the haptic which has been taken out first, so that while you pull the other one, this one does not retract. But with practice, I think we are overcautious in doing this, but with practice, I feel that you really don't need to have anything there. It doesn't get pulled out actually. But still, one is always fearful of it, so to take precautions, one does. So I use one of those silicons which comes with the iris retractors. It goes on perfectly and it sticks also to the haptic, to the loop, so it stays there.
Thank you, Dr. Sanjeev. We have Dr. Ruchit Tewari presenting.
A very good afternoon to everyone, and I thank Dr. Puneet and Dr. Amit for this opportunity. So, yeah. Yeah. So, yeah. So I'll be showing a particular case of giant retinal tear where I performed a pneumatic retinopexy. The case was not successful per se, but then the question is whether the final outcome matters or not. So, so this is the ultraviolet field image of the patient. The left eye is showing a giant retinal tear starting from 2 o'clock to more or less 6 o'clock. Patient has a near total retinal detachment. The macula is off. The conventional wisdom would be to do a vitrectomy with PFO and silicone oil tamponade in this particular case. I had started doing a pneumatic, so I put in C3F8 in this patient, gave him positioning. I started laser, and within the next 2 to 3 days, I could laser most of the break. It was just the inferior edge, which was at 6 o'clock, which could not be lasered. So macula became on from day 1. However, vitrectomy had to be performed. So this is a short video of the vitrectomy. First thing is to take out the gas and do anterior vitrectomy. Now there were few benefits of putting gas in this particular case. First was that vitreous separation had now completely happened. So that made my life quite easy. And only thing left for me to do was to complete the vitrectomy, release all the traction from the edge of the break. So this was followed by indentation. Yeah, so this is followed by indentation vitrectomy. So as you can see, now what I'm dealing with is actually a very small break instead of the entire giant retinal tear. And this made things very easy. I did not require PFCL use in this particular case. I just did a fluid and air fluid exchange, and I did localized laser to the edge of the break that was left. I did not require any further laser augmentation at the edge that was already attached. And the case ended with silicone oil injection. This is the extent of laser that I needed to perform in this particular case. So this is the post-operative picture of the patient. Now there is emulsification of the oil. The patient did not want an early SOR, but as you can see, the retina is well attached. The patient is 6'9" BCVA, and so in the last 2 years since I started doing pneumatic, I've actually done 5 cases of giant retinal tear with an attempted pneumatic retinopexy. Of those 5 eyes, of those 5 eyes, 3 I could complete with a single pneumatic. The surgery became successful. In 2 cases, I needed to do a vitrectomy. In one of those, I required oil, and in the other, C3F8 could suffice. And in neither of those cases, I required PFO. So maybe GRTs are one cases where if we use gas or pneumatic as an initial procedure, it might be beneficial for the final outcome. Thank you.
Yeah, sometime it works, sometime because we know gas injection in these eyes can have very, very severe proliferation. Gas is known to cause, and the fact age is rolled, probably patient already had a PVD, okay, and partly
Yeah.
Partly that way it worked for you, but I mean, yes, because patient was positioning, but it's a double-edged sword. I will be extremely hesitant to use.
So my thing would be, sir, that if we can attach with the concept that attaching the macula with a smaller volume of gas would lead to better visual outcome. Would you want to try that?
No. I'm talking gas injection per se itself, whether irrespective of quantum.
Yeah.
Okay, larger, in fact, larger again, bubble again, what happens is splits the vitreous fibers as well.
Right.
And gas is again known to induce inflammation. And
Yeah.
GRT itself will have hypotonia and other issues. So that's the reason. If you have attached retina, only giant tear, and probably gas works. Previously, we used to do those things. But when already having a totally detached retina and rolled flap, invariably very difficult to put it back. And sometimes, if you have a particularly giant dialysis, I wanted to ask age of the patient, I'm not sure.
There's a 28-year-old male. Sir, a 28-year-old male.
Because what happens sometimes there, you have a age is rolled up, and you have a vitreous is still attached to the base, and then that will not allow.
Never,
of course,
yes.
it got flattened, then that means that was not an issue. But I'll be hesitant because of risk of inducing severe PVR, sometimes can be very bad. Fortunately, it worked out. I mean, yes, sometimes it works, sometimes it doesn't.
Right.
Most of these cases, before you decide for a pneumo, an OCT is very important because you can then understand the vitreous configuration in the central area.
Right.
If you see a PVD, even if it's a little incomplete, it's only attached to the disc, you still can go ahead and pneumo can actually help. But if you don't see that PVD component, it will be difficult for you to predict when you are actually doing it.
Pre-opposition, yeah.
My concern with pneumatic is that the positioning of the patient. So would I be comfortable maintaining this position 22 hours if I were to have a GRT for the next week to 10 days is the problem. So that's one thing which we have to take into consideration as well. And the patient would have to be off work or whatever he is doing for the next week or 10 days. In contrast, if you are doing a vitrectomy and put in perfluorocarbon, the patient is up and about the next day. Same for a scleral buckle as well. So that's something which I think we should think about before we think of doing pneumatic for everything what we do.
Actually, on a lighter note, are we battling with the pneumo or are we battling with Rajiv Muni being aggressive?
Sir, I think it's a learning thing, whether this can be done or not, and whether this works or not.
Yeah, I agree, but then like we are not doing it on our own eyes, right? We are doing it on somebody else's eyes.
Right, sir. That is true. Yeah.
I think the conventional teaching about pneumatic is it should not be done in inferior breaks earlier.
Yeah.
And your failure is, I think, just because of that.
Right, sir. The 6 o'clock edge did not close.
Yeah.
No matter what I did, no matter what position I gave the patient, the 6 o'clock did not close. But then there have been cases where a small break did close. I have those cases where I did pneumatic in a 5 to 6 o'clock hour break, where I did cryo and then lasered later on, and the break did close. So again, it's a hit and miss sort of a thing.
Go ahead.
Yeah, no, see, if you were to, like, we are looking at what Rajiv is presenting, but on the other hand, there was what Dr. Gaurav Shah had presented from a large series of some 10,000, 12,000 patients, in which the success rate in pseudophakic patients was around 50 to 60%. So 40% of pneumatics failed. So that's something which, and this is a series of around 11,000 patients across the country. So that's something which we need to keep in mind.
Right, sir.
See, what happens, positioning is what Dr. Mahesh said. See, 6 o'clock break or any break, you can give a supine position so that you cannot make patient like a Shirshasana. Okay?
Lateral works,
yeah,
sir, in
so
some
lateral
cases.
also no. For that, you need to have enough quantum of gas.
Yes, sir.
Which will not be possible if you have a non-vitrectomy eye. You need to respect physiology and physical properties. Okay, I think use that way. I always say respect physical properties. You're already having a vitreous there, though some liquefied vitreous will create some space, but some vitreous is always there. So that is one part of it. We are not against pneumatic retinopexy, but what happens if you use for a wrong indication, procedure get blamed, everybody blames the procedure. Okay, so all the, including previously we used to talk about RK, it went into bad in a certain way. Not, you use a proper indication, every procedure is good. What we have to look at it here is like looking at a break position, you need that quantum of gas and repeatedly injecting like 2 cc, 3 cc in a non-vitrectomized eyes you are creating problem.
Right, sir.
That is one side of story. If you induce the inflammation, now this peripheral vitreous, which you are compressing against the eye wall and inducing inflammation, it sticks to them. And later on, when you do vitrectomy,
It will not.
you will have difficulty in separating that
Removing
one.
it, right.
You tear the retina, you will have 360-degree conversion.
Then PFCL and right, sir. Thank you.
Thank you. Dr. Shaurya. We'll have three.
Good afternoon, everyone. I'd like to thank the chairpersons, in particular Dr. Amit Khosla, for giving me this opportunity. So basically, I'll be presenting this case of GRT. So this was a 6-year-old male child who came with a history of fall and was operated elsewhere for a lens drop, and had a PCL. As you can see, the patient had a crumpled 360-degree GRT, and I started operating this case. So initially, I tried to kind of separate it with my cutter and the ELU, and I couldn't do that. So I was trying to go bimanual over here. Then I tried putting PFCL, and it still wasn't separating. Then I went in with the forceps. I tried to free the edges of any membranes that I could see, also any membranes that were there inside the cavity. I removed as much as I could. I ate away the membranes. I tried to put more of PFCL, and later I realized that there was actually this membrane that was engulfing all surrounding from the outside. And once I took out this membrane, it kind of freed up the GRT. I ate away the membrane.
Next.
Remove the residual membranes that were there inside once it opened up a bit. And then I put more PFCL when it actually started opening up. Then the edges were again freed of all the membranes. The edges were then diathermized and freshened. And 360 degrees laser was done, followed by a PFCL oil exchange. So this was the next post-operative day, and this was at 1 week. The patient came at 1 month follow-up. The retina was attached. The patient is lost to follow-up right now, so I can't really comment how it is, but thank you.
I think very well managed, I would say that.
Thank you.
Yeah, very well managed. Just goes to show that, like, if you look for a subretinal membrane also, it may not be very obvious. Look for a subretinal membrane also. Very well managed.
Need a lot of patience and time. Only thing you need that's what we need to give. These eyes you need to handle with patience, lot of patience. Work out. Congratulations, actually, I would say.
Thank you.
Thank you, sir. Dr. Puneet next.
Yeah, I'll be showing an unusual phenomena that occurred during a normally looking macular hole surgery. This was a 72 years old male with no systemic history. It was a normal full thickness macular hole, and for this vitrectomy with inverted flap, SF6 gas was planned. So this is the surgery, the routine macular hole surgery. See. So at the time of this fluid air exchange, something happened which caused this whitening, patchy whitening of retina. And this whitening was below the vessels. I initially thought this is ischemia, but the IOP was normal. The surgery was being done on DORC IVA. There was IOP control. The pressure also digitally was normal, so this was not in that time. It was not because of the intraocular raised pressure. I just could not understand what happened. So I did a repeated fluid air exchange, thinking that something toxic has gone inside, and then I closed the case. So this was the post-operative OCT, the hole closed. Angiography I did, there was nothing significant on that. So the question is this, the case is shown here just to show what exactly could have happened, the reason of this whitening. This is the whitening which is not following a vascular thing, and it is below the, within the retinal layers. So this is a question, not any suggestion from my side. Anybody from the panel or in the audience has seen this thing happening?
What did the vision gain in this patient subsequently?
Yeah, vision improved to 6 by 60.
So here you do see inner layer ischemia or inner layer disruption in the post-op OCT. So if you were to look at the post-op OCT, there does seem to be some amount of inner layer distortion, which could have been something like a partial central retinal artery occlusion. Or did the patient have any underlying systemic condition or
No, nothing significant. But this was not looking like a ischemic thing.
Yeah, I understand. But then, like, we do have, I think, like one of my colleagues did have something like this on the table which happened, and then subsequently at the end of the surgery it resolved. So I'm unable to recall. Do you recall, Virangi? Dr. Divyansh had once. We did have one, but I'm unable to recall what was the reason.
He has presented that case in the
I think it was presented in RecNet in one of our classes. Dr. Meru had one, but it resolved the next day itself.
Yeah, correct.
Yeah, next day also, this patient was not having any such
We were not
appearance.
able to come to a
Not able to
come to a reason as to why it is.
Post-op also we had given the routine medications only, and on follow-up also it was stable.
Actually, it's just loud thinking. Is there any emboli which actually caused it and then dislodged?
Yeah, there is a possibility, but
See,
if you see the picture of retina, it is not following a vascular
it's not.
pattern.
It's not.
And there was no pulsations or those kind of things which happens
So
in.
talk about again, again hypothetical. Just during the process, we had a spasm, central retinal artery, and then because of that, like momentarily had that edema. Spasm is relieved because vessels otherwise looks okay, which probably we miss during the transition phase when fluid air exchange, when in between you have a hazy view, multiple bubbles, we miss that one. And then we had this picture, which probably again within those golden period, flow is just re-established. That's me. This is again a hypothetical situation. I think I'm just thinking of possibility. I'm not able to.
Disc could be a little hyperemic in those cases.
Thank you, Dr. Puneet. We have Dr. Shilpi Narwani next, and Dr. Virangi will be ready. So I'll skip my talk for the lack of time. So we have 2 talks remaining.
if yours is ready, you might as well present yours, Virangi. Okay, anyway, she has started.
So, good morning, everyone. Thank you, sir, for the opportunity. So, this is a case of a 16-year-old boy who presented with a history of firecracker injury a day ago. His BCA was hand movements, anterior segment examination showed phacodonosis, and there was no view of the fundus because of the vitreous hemorrhage. So, this was the B scan and the CT scan of the patient. So this was what was the impact which happened because of the blunt injury. So there was complete rupture of all the 3 layers, and there was vitreous hemorrhage accumulation with the plug blocking the defect. So the globe was not collapsed because the blood clot was closing the defect. So the patient was taken for vitrectomy. So while after removing the vitreous hemorrhage, it was noted that there was a large defect at the posterior pole. So this is a schematic presentation. That after clearing the vitreous hemorrhage, there was a large defect which was covered by the vitreous, blood-stained vitreous hemorrhage. So what was the challenge? If we remove the clot, the globe will collapse and the fluid will not be contained in the vitreous cavity. So it was planned to keep the blood clot there only and complete the surgery. So the surrounding vitreous was removed, PFCL was put, peripheral vitreous and vitreous hemorrhage, was removed using the cutter. Following this, the endolaser was done to the break. And 360-degree endolaser was done. Fluid gas exchange was done and followed by silicone oil tamponading. So on follow-ups, this was the picture 1 week later, 2 weeks, 5 weeks and at 9 weeks. So here the query is whether we should remove the clot and fill it with something else, or because on follow-ups we could see there is severe fibrosis. We could save the eye in this patient but not the vision.
It's because the hyaloid has not been separated. So anteriorly, if you see, the hyaloid has not been separated. If it is separated and truncated and left a clot, then this may not have happened. That's one. So that's the reason, because you are shaving the vitreous anteriorly rather than inducing the hyaloid. So put the perfluorocarbon and then anteriorly, if you can separate the hyaloid and truncate it and leave it at that, then this may not have happened. That's one. How many days post-injury did we take the...
1 day.
1 week. Okay,
1
1
day.
week it's
1 day.
reasonably... 1 day. 1 day is, that's a problem. Then in which case you may not be able to. So usually you wait, otherwise, like if, but the other thing is, like you can think of putting a gelatin foam, gel foam you can use to stuff it from inside, or fibrin glue is also an option which could have been used in this situation. So I would have probably induced the PVD anteriorly, left the clot in place and then done laser and done that. That would have been one option which could have tried.
So you have said that we can use the glue or these things, but for that we need to remove the clot.
Yes, the clot has to, in the sense like you can truncate it, leave behind a small bit of the clot and then put the glue on the surface of it. Or you can, one other thing is to put an amniotic membrane. Put a glue and put an amniotic membrane on the surface. That's also another thing which you can try.
Retina was attached on ultrasound, right?
Yes, sir.
Okay.
So one other thing is I would have left the perfluorocarbon in because you can see that fold at the macula. So what I do is to just leave the perfluorocarbon, ask the patient to maintain a supine position, so this fold will flatten out subsequently and then do the laser in the second sitting. That's another thing. It's a very difficult case to manage, but like these are all options which we are thinking, because we have the thing of hindsight. So that's a problem.
Yeah, exactly. That's the same thing, because on table obviously you're seeing like this, but if you wait for maybe a week or so, because it has its own consequences, that's a different issue. So what happens in posterior hole, already we have fibrosis there, hold on, but then you'll be able to, I mean, edema, retinal edema would have subsided. You can comfortably induce PVD all around and leave a small stump there. That's a much safer way. And because outside is already fibrous by the time, it won't leak. But what was the consequence? I mean, whether we could have waited at that time, I do not know. Whether how was IOP and other things. So that is another issue. Yeah.
Thank you.
Thanks.
Last talk of the day, Dr. Berangi Doshi.
Good afternoon, everyone. I shall be presenting a case operated by my mentor and respected Dr. Mahesh. Start. Hello, everyone. Let me take you to a case of a 40-year-old gentleman who was a diabetic and hypertensive since 10 years, had undergone a coronary artery bypass graft, and was recently diagnosed with chronic kidney disease. Having had an unfavorable outcome post 2 surgeries in the right eye and being denied surgery in the left eye, considering its complexity and very guarded prognosis, with a last hope, he visited us on the 4th of July of 2024. On presentation, his best corrected visual acuity was hand movements in the right eye and 6/18 in the left eye. Considering a relatively good vision in his only seeing eye, but a high risk of that eye becoming inoperable if waited for surgery until vision drops, the tough informed call of getting operated in that eye was taken by the patient after being explained of all the risks involved. Wanting to leave no stone unturned, preoperative intravitreal anti-VEGF and autologous blood along with tissue plasminogen activator were injected 2 days prior to the surgery. Taking you through the surgery proper. A 240 BB encircling band was placed since there was no hyaloid separation whatsoever from the disc till the periphery. Diving into the vitreous cavity, after clearing the anterior vitreous, it was noted that it was difficult to figure out the anatomy, with the retina being extremely thinned out, atrophic and ischemic. Hyaloid was noted to be completely plastered to the retina from the disc to the periphery, and multiple careful attempts to avoid tearing the retina and to find a plane of hyaloid separation were done. Multiple such attempts were needed. Following which, a meticulous bimanual dissection was done to remove the hyaloid stuck to the retina. Bridging tractions over the macula were released, and cautiously other fibrous tissue proliferations which are densely adherent to the retina were removed bimanually. Clot management was done intermittently, and further attempts were continued to remove the fibrous tissue proliferations bimanually, painstakingly and tediously. After some dissection was achieved, perfluorocarbon liquid was injected over the posterior hole, and dissection was continued in the periphery. Margins of the breaks created were cauterized, and endolaser was done around the breaks and 360 degrees. Fluid air exchange was done and anterior endolaser was completed. Silicone oil of 1000 centistokes was used as a tamponade for this attached retina. Ports were removed and ends of the band were trimmed, following which Conjunctiva was closed with 7-0 vicral suture. On follow-ups, his retina remained attached under oil with multiple sclerosed vessels, with some reproliferation noted nasally. He subsequently underwent silicone oil removal along with remembrane peeling and reinsertion of silicone oil, followed by cataract surgery. On his recent most follow-up, his best corrected visual acuity was maintained at 6/36 and his retina remains to be attached under oil. Thank you for your patient listening.
Yeah, thank you for the interesting video. Dr. Mahesh was an excellent surgery. So no comments. We have to learn from his surgery, and we have exceeded time. Thank you for your patience, everybody. Thank you so much. Okay, just a photograph and wait.
Thanks, Vinay.
ऊपर आ जाओ